So thank you, Bernie, for the intro. So I'm with Health Literacy Media. I'm the Director of Program Development, and I've been working in the health literacy field for, I guess, about 8 years or so. I also did my training here in the Bay Area at Cal. I focused on mental health services in the refugee and immigrant communities. Most of my work focused on refugees in particular, and I actually worked with Dr. Nelson a little bit with some of our clients. I got my start working with refugees, I think over 10 years ago as an ESL teacher, so in adult education, also citizenship courses, and have volunteered and worked with them in many capacities, and it's a huge passion of mine. So what I'm going to do today is present some practical health literacy strategies. So I've been feverishly typing all day as I'm hearing these wonderful things that everyone's discussing. So I brought some, I prepared some strategies to share, but I also have been including and integrating things we've been talking about throughout the day. So hopefully this will serve as kind of a recap of what we've talked about, but with a focus on the practical application in these populations. So just for some context, I thought it might help to see some numbers. So these are the most recent numbers we could find, but around 42 to 43 million immigrants currently in the US. It's about 13% of our population. The most recent numbers I could find on migrant workers was around 3 million on average. If anyone knows a more updated number, feel free to shout it out. And then we have about 3 million refugees, which is about 1% of our population. And of course, those numbers are in flux right now. But that's currently the numbers that we have. So these are the main kind of areas I'm gonna talk about. But like I said, I'm integrating some themes that we've heard throughout the day. And the strategies I'll discuss are framed in a way that addresses refugees and immigrant and migrant workers' unique mental health challenges and experiences of trauma and different levels of stress. And then with a focus on helping them build a sense of trust and a sense of control in their life, which so many of these people have lost. Due to the fact that they've had to either flee for their lives or make a choice to leave their home to better their lives and their families' lives. And so I think of trauma and these deeper levels of stress on kind of a continuum, while you see refugees who have experienced torture on the end of deep experiences of trauma, and then you have some migrant workers who have made the choice to come. And then a lot of immigrants who have also made a choice and who are happy to be here, but nevertheless, they've all experienced separation from family, having to navigate an extremely complex system, of course, language barriers, and many are away from their support systems when they first get here. So I'll talk a little bit about these topics to kind of frame the discussion. So we know that culture informs many aspects of health, including what people are willing to talk about, who they're willing to talk with, and what they're willing to disclose, and the words that they use. And so this can affect a wide variety of communication skills, from which family member you choose to talk to when you have a whole family in your room or your office, what foods you suggest people eat, how you break bad news. All of these have implications based on people's cultural beliefs. And it's, as we all, anyone who's worked in health literacy for a while and cultural competence knows it's really about awareness of your own cultural beliefs, and then an openness and an awareness of others and the differences. I wanted to bring this topic in, and like I said, I've been integrating throughout the day. I just added this slide, like right before I started talking, because this is a concept I don't hear a lot in the health literacy field, and I'm not sure if people have worked in structural competency. Looks like a lot of people have. Okay, so I just thought it was interesting to bring into the health literacy discussion, and something that Dr. Nelson has told me about. which is this idea, where'd my notes go? This idea that of recognizing the often invisible structural level determinants, biases, inequities, and blind spots that shape people's definitions of health long before the clinical encounter, so long before they even see a doctor or go for care. What are these things that are shaping how they define themselves and define health? So it's a broader view, and it incorporates social determinants, of course, with culture, and focuses clinical care on reducing inequalities at the neighborhood, institutional, and policy level. So this is a field that's doing a lot of work, and there's many people involved in it, and I thought it would just be interesting to mention. Okay. Sorry, I'm too loud? I've never been told I'm too loud. Check, check. Okay. A couple of little anecdotes. We've talked a little bit about cultural or messaging out in the community. And so we know to use words that the community uses, right? So I just thought this was an interesting story. We at HLM, Health Literacy Media, we do testing out in the community of our messages and our documents. And I was working with a group of adult learners, so it was through the St. Louis public school system. And I was showing them a document testing out the wording on a clinical trial summary. So trying to very simply show what this clinical trial did. So it tested a couple medicines in a type of breast cancer, and I kept saying, okay, what about the study? And then we went through this part of the study, and what do you think about this graph? Does this help you understand the study? And I noticed several people kept saying, well, those people didn't do as well because they didn't go to their classes. Those people, their teacher didn't describe the information well enough. They must have not gone to their classes. And I'm like, I'm so confused. And like, to the end of the session, I'm finally like, oh, I'm using the word study. And they think they're associating study with a class. And so they think this is all about people that took a class and either failed or did really well. And I was like, oh my gosh, okay. So I thought the word research study was really simple. And so, in this group, so it taught us that. So that's just the importance of talking with people and really understanding the words that we think are simple aren't all the time. And then, of course, also using key informants. So there's Missouri. We do some community work around our state, and I was putting out a press release in the community called Monette in southern Missouri, and I asked for a quote from a hospital system there about the importance of getting a primary care provider, which we all agreed was a really good thing, and it's a good message. And the hospital was like, this is great, but you do not want us putting this quote out. You don't want this quote from our hospital system. And I, did not understand at all. So I asked them to explain, and they said, well, the larger community here cannot afford care from our hospital. They cannot afford to come see a primary care provider here. You really should get a quote from this free clinic or this clinic over here in this side of town. So again, us just kind of coming into a community, trying to work with the people there and understand their systems, but still, until you really get deep into it, you don't understand kind of those nuances. And then I added from today, Justine's discussion of partner relays and being aware of who the message is coming from. So I thought that was really interesting about does it come from the school or the government, and then the government partnering with community organizations to actually reach individuals. And also that the communication platform matters, that it's simple and easy to use and not requiring a sign-in or is clunky. So here's some features of culturally, maybe structurally informed organizations. Ongoing trainings. So trainings on cultural humility, cultural awareness, trauma-informed care, which I'll discuss a model for that in a little bit. Also, we heard today about trainings that a lot of clinics are implementing trainings for their staff around how to handle the immigration issue and how to talk to their clients about that. Working to ensure that the workforce reflects the cultural mix of the population. And then, of course, offering translation and interpretation services, which I'll also talk about in depth in a couple slides. Ensuring that services are adapted to the needs of the client population. So, for example, working with Latino migrant workers, a way to adapt to their needs might be after-hours appointments, allowing family or larger groups into the clinic visits, using photonovellas or videos instead of materials and things that are very word-heavy. Alicia talked about a media campaign, so meeting the needs of the community, and if there's fear around a certain issue, how can you get that message out? How can you ensure them that there's a safe place? We also heard about Mr. Pereira talked about connecting efforts and work to the political leadership, just like Julia did with her nail salon bill. So really linking the work that you're doing to the systemic and the kind of political movement as well. And lastly, evaluating treatment outcomes by racial, ethnic, and language groups to measure whether strategies are actually improving outcomes. And this allows for adjustments as needed for certain populations. Here's some things that I typed in today. So trying to capture some of the important messages from today. We heard about the really overarching theme around community and connecting with community. So the importance of community involvement, outreach, and tailoring to the community's needs. Dr. Geltman spoke of committing to engage the community and how they can represent their needs, but also inform program development. Building trusting relationships, we heard a lot about that. So Julia spoke about meeting people where they are, meeting people kind of on their own health issues and their own needs, and then moving forward from there. A lot of people talk about having fun, making sessions interactive. I will second and triple and quadruple that. That in ESL, especially, the more fun we had, the more engaged people were. And just a simple smile. I think it was Carrie who said that about a simple smile. And, in my clinical work and in the classroom, I can't emphasize that enough, because these are individuals who are up against an intimidating system every day, and they come into yet another office, to yet another conversation that they could potentially not understand, and just to see a smiling, warm face, I have seen so many times just the tension just completely drop out of their faces, and their wall is down. And so just something as simple as that to build those relationships. And then Jesus talked about how actually just being there step by step and guiding people through the process is a great way to also build relationships. Bringing in providers and resources like shamans, I think someone mentioned that earlier, and the value of social capital and understanding and utilizing people's social networks to engage and care for them. And then there's a nice discussion earlier on how information is collected. So clinics are deciding not to actually chart certain things, immigration status, insurance information, but also spoke to the importance of it so that people could get the care they need, and especially the financial assistance. And then also, Jesus had talked about using verbal, mostly verbal and not written communications. And then many different case management and community health worker models. And I know that in working in resettlement, when refugees come here, that is really the only way many of them can navigate, is if someone is there with them. Expecting someone to just find an address and get on a bus doesn't work with many of them. And then, something also as simple as creating a welcoming environment. So I know at Casa de Salud they use bright colors of paint, and they've taken down mirror or glass and walls and just those simple kind of shifts in the physical environment, what kind of message that can send. This is something that we used a lot whenever we had kind of a new group of refugees coming in. And it's, of course, cannot tell you everything about a culture or about a person, but they're very helpful. And I just wanted to kind of throw the link up there that this is something also staff could use or different people could use to become informed on different cultures. It helped me understand a lot of historical context, so why certain groups were coming to the U.S., what was happening in their country, when they referred to certain terms or certain leaders or certain words. I understood, I had some context for that. So that kind of education was really helpful for us in our clinic. And a couple more. So there's a lot out there. And I want to talk for a minute about trauma-informed care. So we've touched on this like a little bit here and there today, but I thought just having a definition up on a piece of computer slide would just get us all on the same page about what that really means. So a trauma-informed approach to care perceives trauma not simply as a past event, but as a formative one that may be contributing to the client's current state or circumstances. To be trauma-informed is to understand clients and their symptoms in the context of their life experiences and cultures, with an appreciation that some symptoms may represent efforts at coping. So I like this, the shift of not what's wrong with you, but what happened to you, what's happened and what's brought you here, and what's going on. So it recognizes that as an ongoing factor, and just to give a few more examples of some of the experiences of these individuals, I think it helps. I don't know, just helps humanize it a little bit more. But many have been exposed to extreme traumatic experiences in their country. The most reliable number right now among refugees is that up to 35% have experienced torture. A loss of extended family and social networks, difficult journeys for migrants, immigrants, of hunger, fear, hiding, separated from their loved ones, and then detention centers and detention camps. Refugee camps are extremely dangerous and awful places to be, and many spend many years there, just deprived of basic needs. And then, of course, adapting to the new system that they're in. And so it's just keeping that background in mind, and that it might not be that someone doesn't understand. It might be that they're just terrified. And so that's what the trauma-informed framework brings. And this is one model of trauma-informed care that I'll describe, but I wanted to quote Dr. Nelson when he said, "Providers can have a humble, solicitous curiosity." I just really liked that phrase. I want to say it again. And that the biggest barrier to divulging history is that, or social history, is that clinicians never ask. So the importance of just really asking in a really humble way, and then working with the person. Some people want to tell you all about it, and some people don't. Eventually, it tends to come out. He also mentioned integrating trauma training, or training on trauma in medical schools in different disciplines. So social work and psychology and a lot of fields get that type of training, but he mentioned that there's an opportunity for that in medical school as well. So I'm just going to walk through, there's 5 strategies here. So safety is all about creating a sense of safety, of control in a very predictable environment, which we do in mental health, and that I think we can do better in healthcare. And that includes clearly communicating locations and times of where things are in a very predictable way. Clean, orderly spaces are important. Chaotic spaces with lots of papers and colors and things around can be really distressing to people under stress. Keeping clients fully informed of rules, procedures, and expectations. telling them at each step what is going to come next. So just kind of, again, building that predictability into the process. Clear policies on how to report abuse. Availability of security personnel and whether that's triggering or not. Having a policeman or someone security looking in a room can actually be distressing to some people. It can be comforting to others. So just that awareness. And then as far as kind of trauma-informed staff, so training staff on the widespread impact of trauma and the challenges that clientele have faced. Making safe and comfortable time-out spaces. So I worked in resettlement. Our mental health service was on a different floor and in a very comfortable and closed office, and that's where anyone who was kind of having a hard time in distress would come down and have a quiet place to sit, and didn't even need to talk with anyone, but that allowed them to calm down, to go back to the encounter, to go back to the space where they got upset. Separating males and females is often expected in a lot of cultures. Having staff who recognize the signs and symptoms of trauma, and they're trained in de-escalation strategies. And having staff on hand who can identify emotional triggers. Dr. Nelson mentioned to me after his talk that he has a behavioral specialist in the room whenever he's taking a social history, so that he has someone there who has that trained ear to be listening as well and captures that and can build a plan with him. And then respecting client privacy and modesty around, people who have been abused. They might not want to be touched. They might not feel comfortable talking to a male or showing certain parts of their bodies. We talked a lot about trustworthiness, so building a trusting relationship. I'm going to keep going a little bit quickly. Emphasizing and encouraging client choice, and that again gets at that control, that the more choice someone has, the more control they have over their environment and their life. Consistent with the patient-centered approach, collaboration, so treating the patient as the expert, including them in goal setting and evaluation of the services. And then, of course, empowerment, so helping clients understand how their past experiences might be informing what they're actually physically or mentally experiencing now. A lot of people don't see that or know that connection. And focusing on wellness instead of illness. I know there was a meeting recently around interpreters, but I'm going to talk a little bit about what trauma-informed interpreting might look like, and also just to make sure that we're all on the same page about this, is that interpretation refers to verbal communication and translation refers to written. So it is the law to use a qualified interpreter, and there's a very specific definition of what that is, someone who has been trained on medical interpretation. And of course, no cost to the client, and in only emergencies using children and family. We did have to use children and family a lot just because of the kind of a chaotic environment, but whenever it was something really serious, we would have to get on a hotline and use an interpreter that way. So trauma-informed interpreting is just a little twist on kind of just straightforward interpreting. Having that kind of trusted person who knows your language and knows your culture, like Dr. Nelson mentioned, is it's a cultural ambassador in a way, and so that can provide a sense of safety and trust in the room. In smaller communities, clients and interpreters might know each other, so strict confidentiality and training is really important when you're working in a smaller community. And then just recognizing that stigma might be what's stopping someone from talking. It might not be another reason or that they don't understand. It could be the stigma around mental health issues. And quickly, I'll just kind of fly through these, but before the visit, learning your client's preferences. So gender was a big issue. We always tried to link female with female clients and male with male. We couldn't always do it, and some clients didn't care. but just learning how they're most comfortable. Trying to get the same interpreter each time was so key, at least in the mental health field, but that really helps build that alliance and that relationship among the three of you, and it becomes a really safe place for someone to talk about their experience and their health. Scheduling extra time, and you're saying everything multiple times in these situations, so it is going to take more time. And then also briefing the interpreter on the purpose and what terms you might be using and why you're having the visit. Introducing everyone, so especially explaining what everyone's role is, why certain people might be in the room can help build trust. Sitting in a kind of circle or a triangle so you can see each other. And if you ever need training on how to speak directly and cleanly to someone, just try speaking with an interpreter with someone in the room. It's great. It's a great kind of natural way. I learned very quickly how to formulate a brief statement in my head and cohesively say it slowly, but in a really clear way. And And then, of course, redirecting. There are many situations where the interpreter and the client would get into a really long roundabout discussion for 2 minutes, and then the interpreter would turn to me and just say, "She understands." I'm like, okay, there's a lot of like good meat in there, and we have to dig into that. So I'd have to redirect attention a lot. Look at the client, not the interpreter. I saw this a lot, that people were spoken about in third person and not looked at in a room. So treating someone like they're a person and looking at them. Of course, avoiding jargon and paying attention to body language. Let's see, I need to go faster. Briefing after. This was really helpful with interpreters because they would pick up on things that I absolutely could never pick up on in a million years. Certain terms that people use that I interpreted a certain way, they had to tell me after, no, that's not what that word actually means in our culture. That's not what what they're referring to is this. And so that would kind of guide treatment and guide our plan with them. Also, there's a such thing as vicarious trauma. And so some interpreters have also been through traumatic experiences, and it's nice to kind of debrief and check in and make sure that they're okay afterwards. Lots of resources for translated materials out there. And then lastly, we know these kind of standard health literacy approaches, but we can tweak them a little for these populations. So plain language is, of course, communication that everyone can understand. And anyone in the health literacy field knows we can't talk about this without talking about jargon. So I had to put a slide up here about using simple words because even emergency preparedness is jargon and it's difficult to understand. So how can we simplify in our language, and then how can we ensure that that is actually the word used in that language or in that culture? It's not always a direct translation. Focusing on 3 important points, I thought it was interesting. Someone said earlier that they found that their patients didn't like a bulleted list. They didn't want just a bulleted, clean list. They wanted more information. I've also seen it the other way, where people are like, I'm overloaded. This is overwhelming. Just tell me the basics. Tell me the 3 things. So that's really, I think the point is really just to understand your audience and understand who you're talking to. Sometimes people want that information. People come here with high education, and some are quite literate, and they actually want to know this stuff. Some aren't, and some are cognitively overloaded. So something to keep in mind about how much information you're sharing, and do they really need to know the prevalence data on asthma, or should I just tell them what to do in an asthma attack? We all love teachback. And just how interpreters can interpret with the trauma lens, we can do teachback with sensitivity to trauma. And a couple points here. Teachback can be a really nice way of highlighting someone's control over their life, that the fact that their practitioner, their provider wants to hear from them and wants to hear their opinion is just showing that they're valued and that their opinion matters. We can remain aware, this allows us to remain aware of language barriers that could prevent someone from understanding or explaining a concept. And then it's also an opportunity to kind of gauge their cognitive capacity and their stress level. So if someone paying particular attention to their ability to understand and repeat back that information can really be an indicator of, is this person under stress? I feel like they understand me, but they're not able to fully explain this to me. So it's a way to kind of assess that in the moment as well. Let's see. Speaking slowly, I just see that a lot when people are speaking with speakers of other languages, is kind of just, it's in a hurry, or in a clinic, or you're in an environment that's very fast-paced, and the importance of really slowing down and showing the person that you care, that they understand this, sends a huge message. And also tone of voice, and like I said, smiling. And following the client's lead. I've been embarrassed in many situations where I put my hand out and I don't get a handshake, or I go in for a hug and I get like a shoulder bump. So like every culture and every person has their own practices, and so really there's no one way, right? It's just following, and it's just through experience, learning, which groups tend to do which things. And then all of this really is to provide a better kind of empathic, trusting relationship between a provider and a patient. Okay, I think I did it. Okay. Perfect timing. Thank you.